All right. Can everybody hear me? Perfect. Well, I want to welcome everyone today to ABCD's Leap. We are so excited today to welcome Ash Davidson. He's going to give us a great overview. And so I'm going to let you take it away and just talk about if you'll introduce yourself. One thing I do want to mention is if you have questions during, we are going to hold those until the end. So please either type them in the chat or just wait for the toward the end of the webinar and we will get to everyone's question. So, Ash?
Thank you so much, Carrie. Hi, everybody. I'm Ash. It is a pleasure to be here with you today. I'm excited to share some information, and then we'll spend sort of about the first half today talking through some practical strategies, some grounding information about barriers and things that LGBTQIA plus patients face. And then we're going to spend some time towards the end doing some Q&A with a couple of people that are here in the room with us as well to hear more about some sort of personal effects and their experience as well. So that's kind of what the format's going to be today. And I'm going to go ahead and share my screen really quickly and we will get into it. Okay. So, like we said, this is me. I'm Ash. In October of 2022, I went in for gender affirming top surgery. It was one of the most exciting, anticipated moments of my life. And about 11 days after that surgery, I actually got a phone call from my surgeon and found out that during the surgery, unexpectedly, they had found a tumor and I was being diagnosed with breast or chest cancer. And ever since then, really, I've really committed myself to doing advocacy work based on the experiences that I had through my cancer care. I just realized that there were some things about my care that I wanted to see done differently. And I didn't know at the time that I could affect that, but over time I realized that through advocacy work and doing things like this, that we could share information and try to make a dent in some of those things that I wished were available to me when I went through treatment. One quick note about language. We're going to talk about a lot about language today, but I'm going to surface this right up front. You'll see here that I even said breast or chest cancer. We know clinically that there is a difference between breast cancer and chest cancer, but we've heard feedback from folks where sometimes even just the word breast in front of cancer can feel exclusive. It can feel like not everybody's included in that. And so often we try to make sure, as in many places as possible, to use that breast slash chest cancer, just to, again, to make sure that we're using more inclusive language that doesn't make people feel like they don't belong. So some of the things that we're going to do today. One, we're just going to recognize how LGBTQIA plus identity and breast and chest cancer support intersect. We're also going to apply practical communication and support strategies. And these strategies are designed to help patients, survivors, caregivers, mentors, and mentees, everybody they can think of really, to make sure that they feel more respected and safe. And then we're also going to identify ways that mentorship programs and breast and chest cancer organizations can strengthen inclusion. And a quick note, I'm here today on behalf of the Cancer Network. We do a lot of different work in this space, but there are three main pillars that we really focus on are one, education, advocacy, and training. If you want more information about the Cancer Network, you're welcome to visit our website as well. So as we get started here, one of the things that I think it's important for all of us to sort of ground ourselves in the landscape and the things that we face as LGBTQIA plus patients, like we said, caregivers, mentors, mentees. This is really about everybody. So I'm going to go through some of these slides a little quickly so we can make sure that we have time to get through some of our more practical strategies in the Q&A session at the end. So if you have more questions about some of this information and data, please feel free again to put that in the chat and we can follow up later. So if I move through some of this a little quickly, don't worry, we can always follow up with you. But we want to really cover off on how legislation affects us. We know that right now, as of May this month, there are 529 anti-LGBTQ plus bills circulating in U.S. legislation right now. Last year, there were over 700 anti-LGBTQI plus bills introduced in 49 states. The good news is that only about 8% of those became law, but we also know that even if those bills don't pass, they cause harm. We've got data from MAP from October of 2025 that says that 73% of LGBTQIA plus adults and 84% of trans adults report that the political climate has negatively impacted their well-being. We also know that there's been funding cuts to both LGBTQIA plus health research and cancer research. And so when you combine those cuts together, that means that LGBTQIA folks are not showing up in data and research. Some of the disparities that we face, and I won't read every single one of these to you, but I think there's some here that are important to highlight why there's a difference in the ways that we function and view healthcare. 40% of people surveyed didn't know about recommended screenings. And another 35% said that their providers didn't discuss them with them. We also know that 28% of trans and non-binary adults avoid or delayed care due to anticipated mistreatment. So not even due to treatment that they had received, but just their fears around being mistreated. This also results in things like 2 times longer delays in diagnosis and a 3 times higher rate of recurrence. And I want to take a quick moment to talk about social determinants of health, because these are factors that come into play that impact our access to healthcare and the barriers we face, and it can impact our outcomes. So when we talk about social determinants of health, we're talking about everything from things like housing, employment, insurance and healthcare access, our social support and community support, things like discrimination and racism, even down to transportation, education, and environment. And when we talk about how these things can be impacted, when we see things with higher rates of housing instability due to things like family rejection, employment discrimination that might affect our financial stability, and our access to insurance. And even if we do have that insurance, we're also finding that there's insurance gaps now for gender affirming or reproductive care. We also see limited social support in non-affirming communities and a higher exposure to discrimination in healthcare. So all of these things combine together to impact just how LGBTQIA plus folks think about healthcare, how they feel like they belong in healthcare settings, and even if they're able to access it at all. But this isn't all doom and gloom. There are some good things here. And so when we're talking about the population of LGBTQIA folks across the country, more than 9% of US adults identify as such. We have nearly 1 in 4 adults under 30 identify as LGBTQIA+. So we are here and we are not going anywhere. We exist across every race, class, religion, ability, and geography. Yet we know, like we just talked about, that we're underrepresented in research and survivorship data. But we also have heard from our own out survey in 2022 that the Cancer Network conducted, that we know that care satisfaction is higher if environments are welcoming to LGBTQIA plus folks. So before we get into some specific strategies about how to create more inclusive environments, I want to spend a little bit of time just grounding ourselves in what's bias and what are microaggressions. So bias, for example, these are just our learned assumptions or mental shortcuts that influence our perception and decision-making abilities. And then microaggressions are subtle comments or actions that convey these biases or stereotypes. We have a couple of different types of bias. We have implicit bias. This is bias that operates automatically outside of our conscious awareness often. And then we have explicit bias. This is bias that's consciously held and acted on. And we also know that patients may not even recognize bias in the moment, or they may choose not to name it due to fear or concern about the consequences of speaking up. So it's important for us to talk about this in these rooms so we're not always counting on somebody else to tell us when maybe we've said something that makes them feel uncomfortable or that doesn't make them feel seen. So let's talk about some of the ways that bias can affect LGBTQIA plus people, because it doesn't have to be intentional or overt to have an impact on people. Some of the ways that it shows up in our patient experience can be things like just our concerns being minimized, redirected, or not even fully explored. It also leads to assumptions and asking questions instead of open-ended questions, but making assumptions without even asking questions. It can also lead to delayed follow-ups and inconsistencies in the way that care is applied. Some of the ways that patients might respond to this sort of things is downplaying their own discomfort or confusion. They may stop asking questions or even raising concerns. Again, feeling like they don't have a voice in their own treatment can be incredibly detrimental to their experience and their access to care. And they may start to even normalize experiences that are actually inequitable. So, what do we do? How do we help? There's a handful of different ways. One, we can validate, so acknowledge people's feelings and their experiences. Another thing we can do is redirect, gently correct, or shift the conversation away from harm. And we'll talk a little bit later about how we can do that. Documentation and escalation are two ways where we can track repeated incidences, make sure that those are shared with leadership in your organizations to make sure that, again, we're keeping track of these things. And if we're starting to see patterns of bias or microaggressions or other things that are showing up in care, that those can be addressed. And then again, overall, just protecting trust, ensuring that patients don't disengage from care because of bias. So how do we know what bias is? And this, I know this feels like a landscape full of landmines for people. We don't know what to say or how to say it, and what to avoid and what not to avoid. So here are some skills and tips to watch out for. So things like minimizing or dismissing something. So this could look like something saying, "Oh, that's probably just stress," or "Let's not worry about that right now." Other examples of deflection or redirection that likely are not very helpful in these settings is, "That's outside the scope of this visit," or "Let's stay focused on this main issue." Making assumptions is another one, saying things like, "You don't really need to think about that," or "Patients like you usually," and then limiting our choices, right? "Well, this is just how we do it," or "There aren't really any other options." These are all ways that we can common language that we've probably all used at some point in time that can actually signal bias to other folks. So now that we've talked about bias and microaggressions, and there's just a note too, there's an appendix at the end of this presentation too that has some more details about some things to say, what not to say as it results to bias. And as we get into this next section, we're also going to cover some things to say or things not to say. So as we talk about communicating respect, this is just being mindful of inclusive communication, because it's a great way to build trust with the people that you're working with. And again, it's not just about being respectful or polite. This is essential. It signals safety. And we also know that even one small moment of misgendering or dismissal can start to undo trust and even cause people to disengage from care. So again, let's review some things or some terminology that we think are either outdated or can even create harm. So things like the term preferred pronouns. The issue with preferred pronouns is that it implies that pronouns are optional or they're a preference. Instead, you could use something like, "What pronouns do you use?" or "Can you remind me of your pronouns?" And another note here, if wearing a pronoun pin and introducing yourself using your pronouns can signal to people that you'll respect theirs. So for example, if I go and I'm meeting with a new oncologist, for example, if they're wearing a pronoun pin, or if they say, "Hi, my name is Dr. So-and-so, I use she, her pronouns," I know immediately at that point in time, without them knowing anything about me, that they understand the importance of pronouns, and I'm immediately going to be a bit disarmed and probably more comfortable in their care. Another term, biological sex. The problem with this one is it reduces someone to their anatomy chromosomes, and it ignores gender diversity. So a term instead to use would be sex assigned at birth. Another term, real name, when you're asking about someone's legal name, their chosen name. But when we use the term real name, it suggests that any other name that they go by is not real. So again, asking questions is a great way to understand what someone's needs are. So saying something like, what name would you like me to use? Or what name should be on your chart is a great way to make sure that you can follow their lead to make sure that they feel included and respected and cared for. Another term, transgendered. The problem with this one, it's incorrect grammar. It's also outdated and is considered fairly offensive. So using things like transgender person or simply trans person is a better option. A few more terms here on the next slide. Homosexual. This one I think sometimes surprises people that this is maybe a what not to say. And it's a bit outdated of a term. It's also often tied to medical stigma. And so, again, mirroring people using the terminology they use or even asking them, using more specific terms like gay, lesbian, bisexual, etc. Again, taking their lead is a great way to make sure that you're mirroring the patient and their needs. Another term, sex change. The problem with this one is it reduces identity down to medical procedures and it's an invasion of privacy. So instead, using terms like gender affirming care or even transition related care are much more appropriate. And the last one we're going to cover here is both genders or opposite sex. And the issue with this one is it completely erases non-binary people and it assumes gender, there are only two options. So using terms like gender expansive or people of different genders, again, is a more appropriate way to communicate. So just some quick tips here on what we've covered so far. Some ways that you can practice these things. Again, people are we're always worried, are we going to say the wrong thing? And then what do we do if we say the wrong thing? And how do we recover from that? And is the person, never going to want to talk to me ever again? And typically, generally, that's not true, but some ways that you can avoid some of that are these tips. So one, have practice conversations in your head or even within your organizations. If there's a coworker or colleague that you work with and you want to try to make sure that you're incorporating these things, maybe see if somebody will kind of go through some scenarios with you. Another one, treat inclusion as a daily practice. It's not a one-time event. It's something to practice every single day. Another thing to be careful of, focusing on current health needs, and be careful not to overemphasize on gender and identity. And tailored care can be more inclusive than a one-size-fits-all approach. And again, if you make a mistake, a short apology and a quick affirmation go much further than silence. And how do we repair those communication mistakes? This is a very, very simple example, but I think it really drives home the point that acknowledging, apologizing, and then adjusting can go a long way with people. So in this scenario, it's simple. Say you meet somebody for the first time and you accidentally misgender them. What do? Thanks for letting me know. I'll be sure to use your correct pronouns moving forward. It's as simple as that. Quick and calm corrections model respect and they build trust faster than silence. Basically, if you handle mistakes well, it can help strengthen relationships. So let's talk a little bit more about establishing safety and trust with communication. So we know that not everybody feels comfortable sharing their identity right off the bat when they're in a new healthcare setting or even in any healthcare setting. And so disclosure truly is an act of trust, and it's not something that your patients or mentors, mentees, anybody are obligated to do. But when somebody does share their identity, when they do choose to disclose to you, you don't actually even need to know what their identity is to create a welcoming environment for them. So these are some, again, whether somebody has shared their identity with you or not, disclosed and kind of given you their trust, there are things that you can do here, regardless of what situation you're in there, that can continue to signal these trustful environments for folks. So again, mirroring their words and pronouns, asking permission before sharing details with others, making sure the documentation is correct and accurate, making sure that their name and pronouns are in correctly. When asked, it's perfectly appropriate to offer identity-specific support. And one thing to avoid in written communications, making gendered assumptions, using something like hi in the person's name as opposed to hi, ladies. And for an example here, at some point recently, I was on a group email thread, and the group email thread started with hi, ladies. And I immediately was like, I don't know. Am I a lady? Is this for me? Should I be reading this? So even just that simple thing that we kind of, it's a really easy slip to make, can often kind of cause people to not know if they're even included in the conversation. And again, disclosure is not an obligation. And so even if there are things in someone's chart or information that you have that tips you off to knowing that they may have something to disclose at some point in time, whether they ever do or not, you could still create really safe environments for folks without them ever having to feel the pressure of disclosing anything about their gender or identity to you. Again, introduce folks using your name and pronouns. Ask everyone what name they would like to use, and incorporate neutral family language into your communication strategy. So saying something like, who's your support system, rather instead of who's your family, husband, or wife. Again, these are practices that you can use with every single person. You don't need to know anything about their gender or identity to use these across the board in your day-to-day practice. So let's cover a few more tips and ideas for creating inclusive spaces and systems. Because again, like we said, this isn't just about politeness or kind words. This is stuff that shows up system-wide in everything that we interface with. Forms, signage, support groups, staff trainings, and how organizations present themselves. And another note here is that inclusion also lives outside of your organization when you're thinking about things like referral networks and specialty care. So as you're referring folks outside of your network, understanding about, am I referring people to inclusive networks as well, and being able to sort of see and vet for yourself to make sure that you don't send somebody to a specialty care or to another referral that may not respect or treat them with dignity. So why does this matter? We just said this is built into everything that we touch. Again, workflows, even restaurants, staff habits. And so one of the things that we've seen is in our current climate, many organizations have removed things like flags, pins, inclusive web copy, often to protect their own funding. But we know that patients have noticed this absence. And the impact of this is again, folks are delaying or avoiding care. They're presenting later in disease. And trust is often eroded, even if people are kind to them. So how can we help? This is a bit of a repeat of what we've already said, but this is about modeling it, not just for yourself, not just for your patients, but even for your colleagues and the people that you have touch points with every single day. So whether that's providing quick or calm corrections in real time, or again, practicing some of these strategies that we've already covered, making sure that you're the model and folks can look to you also to make sure that these strategies are being implemented. And then even things like offering options depending on how you're interacting with folks, whether that's in person, maybe vetting ahead of time to see if the provider that they're going to see does have safer restroom options for them, even recommending at times like if somebody's overwhelmed with care or feeling like they're not being treated with dignity, encouraging them to pause or even disengage for a moment, reschedule an appointment, or just regroup. Those are all great ways to sort of help somebody who's feeling like the system right now is against them. We just covered this for a little bit, but I'm going to get a little deeper into being a model, setting the tone for inclusion, and some of the ways that you can do that. You can audit your own touch points. So look at things like intake forms, email templates, website copy, autoresponders. Do they assume gender or family structure? Can you make updates to those things and make them feel more inclusive? Using inclusive language by default in all of your written and verbal communication before you know anything about the person that you're talking to. Another great way is to normalize it internally. If you hear a colleague misgender or make an assumption, a calm, quick correction models the standard. Saying something like, actually, they use they, them. Again, quick, calm, non-judgmental is a great way to just be able to help correct even people that are well-meaning. And then building allies. Share this information with others. Allyship is huge. It's even more important today, that making sure that as an ally, that you're also sharing this information and not waiting for it to come to you, but putting it out into the world as well. We know these proactive moves can prevent harm, they can reduce anxiety, and they can make people feel seen from the very start. I want to take a quick moment also to just comment on trauma-informed framework, because I think these 6 principles are important to understand as they apply to oncology. And so I'm not going to spend a lot of time on this. This is information that if you want some more detail on, please feel free to follow up and we can give you some more information. But these 6 core principles are incredibly important because we know that cancer care itself can be traumatic. We also know that LGBTQIA plus patients often carry additional trauma from past medical bias or even some of the social determinants of health that we spoke about, or just their lived experiences. And so applying trauma-informed care can help prevent more trauma and supports healing. So being mindful of creating a safe environment, building trust and transparency, establishing peer support, focusing on collaboration and mutuality, empowerment, voice, and choice, making sure the patient is centered and feels autonomy and that they have a say in their care. And then also being mindful of cultural, historical, and gender sensitivity and recognizing the stigma, the bias that we spoke about, and diverse identities. So let's cover a few of the takeaways that we just went over. 1, inclusion is a practice. It's not a policy. It shows up in every interaction, every communication, and our system touch points. Making sure you treat it as a practice and a day-to-day practice rather than a one-time event will go a long way in making sure that it becomes a routine. Small, consistent actions build trust. Using someone's name, following their lead, asking questions, and correcting mistakes calmly goes much further than you think. And safety isn't assumed, it's created. And everybody has a role in making sure that that safety is built. So now that we've kind of covered all of that, we've got some time here where I'm going to ask a few questions. We have both, I believe, Jamie and Jane are here in the audience. So I'm going to ask a couple of questions. And also, if there's anybody else here in the audience today, as I ask these questions, if you want to speak up and share your experience, please feel free to. The floor is open to everybody, but I also want to make sure that Jamie and Jane have a chance to answer as well. So we're just going to talk a little bit about how mentorship is important and some of the barriers and things that they've faced as well. So I'm going to go ahead and start with my first question. And I'm going to go ahead, Jamie, if it's okay with you, I'm going to put you on the spot to start us off on the first question. And actually, if you could, before you answer, please just share your name, your connection to ABCD, and one thing that's been making you happy lately. So Jamie, go ahead and introduce yourself, and then I'll ask you the first question.
Hi, everybody. My name is Jamie Phillips. I'm in New York City, and I've been part of ABCD for probably up to 4 or 5 years. Found out about it through my diagnosis and had a mentor, and now I'm a mentee. I'm sorry, I had a mentor, and now I'm a mentor. And what else should you know about me? One thing that's making me happy is just great weather, and I'm very thrilled that I'm healthy and can get on my bike. I just completed the Live Strong program at the YMCA, so that was a bonus. So yeah, finally it was open after all the pandemic years.
Awesome.
Yeah, thanks for having me. Yeah.
Yeah, absolutely, Jamie. Thank you so much. So I'll go ahead and kick off with the first question to you. But when you think about your breast or chest cancer experience, was there a moment where you felt unseen, misunderstood, or like the space wasn't built for you? Or even alternatively,
Yeah,
was there a particular moment where you truly felt seen?
sure. Yeah, thanks, Ash. I'm fortunate that I'm in New York City and it's a very progressive city. So off the bat, uh, I didn't experience anything that would have felt, that would have bristled me around my gender or sexuality at all, other than, at 49 being asked if I was possibly pregnant before I had my surgery. It's like on many levels, no. She's like, we have to ask. So no. And I have to say, like literally before I went into my surgery, maybe TMI, but whatever. This is really relevant to my experience as a genderqueer person, a queer person. I feel like I was like getting my period literally like hours before I went into my surgery. And I was like, what do I do? And they gave me these like diaper boy shorts that I was really psyched about. I was like, these are awesome. Like if I ever need these again, like where'd you get these? So that was an unintended like little positive moment as I'm literally getting wheeled in this like empty hospital because it was the pandemic. I would say that where I really felt it was in some of the conversations in a support group I was in that wasn't necessarily LGBT support, but around like experiencing sudden menopause because of my treatment, both the chemo and then the ongoing AIs. And that was the first place that I felt like a total oddball. Like how did I get into this conversation? Like, I feel like it's puberty all over again. And I was just not comfortable at all. Nobody said anything that was not comfortable, but it was just clearly like, how did I get into this room? It felt the conversation felt really different. The reference points that people gave, and by and large, I'm really glad menopause is having its moment. But on the whole, it feels like a very sort of like heterosexually driven
Yeah,
renaissance. So
yeah,
I can't say that was unique to my cancer experience per se, but to be in the stress of dealing with post chemo and radiation and what is happening to my body, that felt weird.
yeah.
Or yeah, so not otherwise, I feel grateful. And the other place I think I might have felt seen is I'm very resourceful, and I was looking out for resources, and I tried to find the name of the author today, but I just couldn't. But there was a graphic novel I read about an individual that went through cancer as like a genderqueer person, and just listening to their experiences or reading about their experiences was really affirming. So
Awesome.
thanks.
Yeah, Jamie, thank you so much for sharing that. And I think, there's a couple of things that you touched on. And one, I think your perspective is really important because hearing that you didn't face a lot of barriers to care and to getting the care that you needed, I think
Mhm.
is important because we do hear a lot of horror stories, and those stories are important to hear as well. But I also think when we talk about medical mistrust and the reasons that people avoid care, hearing some stories from folks like you that said, hey, there were some moments that I faced that I didn't love, but I didn't have, these high barriers to even just getting care are important because it means that people can feel a little less fearful potentially. And so your perspective is really important there. And then, I think also, you brought up a point that I found in my own experience as well, which is sometimes we think of those barriers just preventing people to getting into care in general, but we don't think about the barriers as they come into survivorship and into these other sort of ancillary parts of everything that makes up this cancer experience. And so encountering a support group that maybe they didn't do anything or say anything that was overtly discriminatory, but you just, language or other or attitudes didn't make you feel fully included, I think is something that we hear a lot. I experienced it as well, and I know a lot of other people that have. And so I think that's why these conversations are so important, because understanding that this can show up anywhere along the continuum is really, really mindful for folks.
And I just wanted to add one little extra point is that
Please.
had it not been the pandemic and like nobody was getting elective surgery, I mean, I was diagnosed in August of 2020. So this was like 5 months in, no vaccine, like sirens everywhere in New York. Like it would have been interesting if somebody had ever asked me, like, have you thought about top surgery or breast reduction surgery or something? Like I almost wanted to have had that conversation as part of, well, we're in there anyway, but it just wasn't ever discussed. And I wasn't even thinking about, it was in the back of my mind, but it was a pandemic, I want to get in and out of there. So yeah, but it would be interesting if there were like a larger conversation about, how are you feeling about this? And I'm fortunate that I only needed a lumpectomy, so that's where my gratitude lies for real. But yeah, I just wanted to mention that. And I would love to hear what Jane has to say. I want to take up all the time.
Yeah, no, absolutely. And that's a perfect segue. Jane, if you'd like to go ahead and introduce yourself as well, and if you'd like to answer the same question, is there a moment where you felt particularly unseen or misunderstood, or alternatively, was there a moment that made you feel truly seen? Oh, Jane, I think you're on mute.
Okay, I tapped it. Did I unmute?
Yep, you're good.
Okay, my apologies. I'm not a big Zoomer. Um, Actually, one thing that I'm very happy about is I have a new dog, and the dog is quite the Zoomer, so she's keeping me active. I was I was diagnosed with breast cancer a number of years ago, back like 16 years ago. So my experience is a bit in the rear view mirror, which is a good thing. But when I was first diagnosed, I knew that I wanted to have a mastectomy, and I actually wanted to have a bilateral mastectomy. And I knew myself pretty well. My partner and I both agreed on this. She didn't care, that I didn't have breasts, and I just wanted them gone to remove my worry about future cancers, even though I knew that medically it was probably not going to make a big difference. Anyway, my surgeon, male, did not like that idea at all. And that was a time when I really didn't feel listened to, that despite being 50 years old, it seemed like I probably didn't know myself and I might regret this decision that I was making. Um, but I also understood that this was an emotional time, and perhaps I wasn't in the best place to make that decision. So I went ahead and only had the unilateral mastectomy. And for 3 years, I had that. And for 3 years, I was not happy about it. I did not like walking around having just one breast. And so I went to another surgeon 3 years later. This happened to be a female surgeon. And I was all psyched up with all my argument. And I began to tell what I wanted to have done. And the surgeon looked at me and kind of stopped me and said, I get it. You've thought about this. This is what you want. You have a right to be symmetrical. And when do you want to schedule this? So it was when that happened, as soon as she said the first words out of her mouth, this big sense of relief washed over me. And it was clear that I knew that this was the right decision. So I was very grateful for that second encounter.
Yeah, absolutely. I think the difference it makes when somebody just says, "I get it," and they offer you, the choices that you feel are best for yourself, and they reaffirm those, it makes a huge difference for everybody. Okay, I'm going to go on to the next question. Let's get into mentorship a little bit. and I want to be sort of mindful of our time. So this is going to be kind of a two-part question. Again, Jamie, please feel free to answer this, both of you. But let's talk about how mentorship has shaped you through your treatment, either as a mentor, a mentee, and also why you think LGBTQIA specific mentorship matters.
Oh, this is Jane. I would, in terms of the latter part, I honestly don't know that I've ever been referred through ABCD a person who was LGBT. So I have always sort of kept my my sexuality or my history to myself until something came up from that mentee. So I don't, and I wish that more had happened, but it just happens to be my experience.
Okay.
Yeah, I'll chime in. I think my mentor is on the phone, on the call, Kathy. My mentor, and I had different experience in this realm, but I never felt that it was an issue. And she just welcomed all the things I had to say, and I had a lot to say. So very grateful for her. And because I wasn't experiencing, huge barriers in this respect, it wasn't really so much of an issue. Although I'm confident that she would have, supported me through everything. It has meant a lot to me to be a mentor for individuals who identify as LGBTQIA or genderqueer, because if I'm the person that provides that kind of affirmation and validation that person might not be getting otherwise, like that's huge, right? And I think when you talk about being queer, there's just such it's a non-binary, and there's so many different ways in which queer people experience the world, and to have a mentor that also is cognizant of that rainbow of possibilities, I think makes a big difference, because I don't think the medical system is really equipped for that, even at their best day, right? So I think having a human being that's been through this and can acknowledge all the different shades of the rainbow. I mean, I ask my mentees, but I think I'm glad to fill that role, to be there for somebody, for sure.
Yeah, absolutely. I think in a mentorship setting, having the opportunity to have a mentor, or be mentored by somebody who's walked in a similar lived experience as you. There's almost a secondhand language sometimes there, where you don't always have to there are fewer things you have to explain up front, and I think that can make a big difference in these kind of settings as well.
Right. And not only that, but if queer people have already experienced some kind of discrimination, they might be less likely to even expect that from their healthcare provider. So then, in a sense, like a peer becomes even more important, because they might share more there anyway.
Yeah, no, that's a great point. Okay, I'm going to move on to the next question. For both of you, Jane and Jamie, if there's one piece of advice that you could give for folks who are supporting LGBTQIA plus people in breast or chest cancer, what would you suggest?
And my suggestion would be, to ask, what other support do you think would be useful for you? Where are you not feeling the support that you wish you had? And, let's talk about that, and let's work through this. As someone that, again, experiencing cancer, there was so much on my mind. I was so flooded with the new cancer world that, I didn't always think about everything that I wanted or needed. And just having the question posed, what would I think, looking back, I mean, again, I don't feel like anything was particularly lacking, but it might be useful to hear that. Like, where else are you experiencing this? What can we find? How can we support you?
Yeah, I think that's a great suggestion.
I would second that. And then just advice for myself and for everybody is just ask the questions, and then try to take your time and just deeply listen to what the person is saying, or what they're trying to say, or what they can't say. That's not a magic bullet, but I think just compassionate listening goes a long way.
Yeah, no, and I think that's a really valuable suggestion. Often people are trying to figure out, what are these tools, tips, tricks? What are the strategies? And I think, Jane, that's a really good reminder of just listen without judgment, without preconception. Just listen to the person and try to hear about them and meet them where they are. I think is really, really helpful advice. Okay, I know we're getting towards the end. And there's a couple of slides left to share, but before I share the last couple of slides, and I know there's not a ton of time for Q&A, but I did want to also ask Jane and Jamie, we are on the cusp of Pride Month. June is Pride Month for everybody here, and so we are almost there. There are a lot, I think, of things that make Pride Month both a celebration. It's also a reminder that Pride is a protest, and that this year we are as queer folks facing a lot of outside pressures, a lot of legal pressures, a lot of things in our lives that sometimes make it a little bit harder to be vocal, to be visible, and not all of us can be. So if there's any message that you have to share as we're going into Pride Month, please share it with folks.
I guess I would say, we're all on this earth together. It's really hard times that so many of us are going through. We all have our unique and separate journeys. But if we can just remember that we're humans, to be kind to each other, to be true to ourselves, and be kind.
Yeah, that's a beautiful message. And I would say, this is the celebration month. It is also political, absolutely, but life is hard, and having cancer is really hard. And if there's a way to just celebrate the freedom of being who you are, then let's celebrate that, because it goes deeper than any illness or challenge. You have to feed your soul. Absolutely. The fight is always going to be there, but feed your soul, enjoy it. Yeah. As I like to say in New York, the weather is gay here in June. What time is it? Gay. It's really gay in New York. So, let it be. There'll be a lot of happiness too. So.
Absolutely. And thank you both so much for sharing your perspectives and those messages. I think they're messages that we could take into not just Pride Month, but every single day, which is be kind and celebrate. I think you both really just kind of wrapped it up in just the most eloquent and sort of simplistically beautiful way, which is be kind to each other, and let's make sure that we enjoy the good things in our lives and celebrate and stand up for those things. So again, thank you so much for your perspectives here. I'm going to move into our last couple of slides, and then if there's time for a couple of questions, we'll take those right at the very end. Okay, and I'm going to pose one question to everybody here. You don't have to answer this in the chat, but just something to think about. But what's one thing, in light of the things you've learned today, that you could do tomorrow to make your practice more inclusive? I'm also going to share a handful of resources here. These are resources that you can find on the Cancer Network website. We've got a welcoming provider directory. We've also got some information that if you are a provider and would like to learn about how you could be added to this directory, please let us know. We've got information on best and promising practices, how to ensure that organizations follow some of these inclusive practices that we spoke about today. We've also got a training module. We have both an 8 module version and a shorter 1-hour version of welcoming spaces. This is self-paced training to improve your understanding of how to create these welcoming spaces. We have support groups. We've also done 2 groundbreaking community research initiatives called the Out Surveys. Those you can find more information about those on our website. And then also we have an entire resource library with more there that you can find as well. And please, this is a really important thing. If you could take the time to scan this QR code that you see on your screen, or we can also follow up and make sure that you have it beyond right now. But your feedback is incredibly important to us. It helps us make sure that these trainings and these webinars that we're doing, that we're doing it the right way, or if there's things that you feel like are missing, or you've got feedback for us, constructive criticism, anything that you think that you feel like is important to share with us. It means a lot to us, and it really helps us continue to make sure that we're getting information out there that you want to hear. So please feel free to go ahead and scan this and let us know what you thought. And then, like I said, there's an appendix here with some more slides that I won't sort of spend any time on here, some more information about determinants of health, and then again, our contact information here. So all of that said, if there are any questions, I know we've only got a couple of minutes left, but happy to field some questions.
Yeah, Ash, there's a couple questions in the chat. So one from Ashley about the aesthetic flat closure or flat groups. She's just mentioning that right now there are it's mostly female, but like, are there better ways to say that? Is that a good term, like flat closure, when people, are choosing not to do any type of reconstruction? Does it feel inclusive? I mean, it is more of a medical plastic surgeon term, but then, in some of the flat closure support groups, is that term feel inclusive?
Sure. I think the term flat closure, you're gonna get my personal input here, which is I don't think that it signals any type of lack of inclusivity. I think, again, it is really kind of more of a specific kind of medical term and procedure. But I think when we talk about these groups and are they inclusive, are they not inclusive, it's really around this idea that, like, really recognizing and understanding the fact that, not everybody who chooses flat closure, or I know somebody actually who recently their reconstruction ended up sort of failing, and so they after chose to go with a flat closure, and so that not everybody who has breast or chest cancer is a woman, or identifies as a woman. There are cis men who have breast cancer, and there are trans and non-binary and gender expansive folks across the board. And so in those groups, I think it's really more important to have conversations with folks and to figure out if there's terminology or if there's subject matter that's coming up that may make them not feel inclusive, as opposed to the specific medical terminology. And so I think that's where those nuances can come into play. And those, again, just frank and honest conversations can go a long way.
Great. Thank you for sharing that. So I think we'll wrap it there. I do want everyone to know that we are so grateful, and a huge thank you to the Cancer Network, to Ash for coming on here. This is a perfect ABCD leap. So our learn, engage, and persevere. And that's what we want everyone to do. So everyone, anyone, any stage, anywhere, are welcome to request a mentor with ABCD, become a mentor, share as much or as little of your story as you want to, but really to feel safe. And as Ash mentioned, referrals, if you're part of our partner community, we're so happy to have you here. And just know, when you are referring people over to ABCD, that we are here and we are supporting anyone, especially in this community. And our specific LGBTQIA mentor training next month, we're hoping that we make everyone proud and that everyone understands that we're here to support them. Those mentor connections are so important. Again, thank you, Jamie and Jane, for being ABCD mentors, for sharing your story, and for making people feel seen, heard, and safe. So everyone have a great day. We will send out this presentation, Ash's contact information, the Cancer Network's information, as well as some other resources. And if you guys have any questions, please feel free to reach out to any of us. But thank you so much.
Thank you, everybody.
Have a good rest of your day.
Yeah, be well.
Bye.